Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about advances in radiotherapy for cancer patients with Dr. Kimberly Johung. Dr. Johung is an associate professor of therapeutic radiology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Well, Kimberly, let's have you maybe tell us a little bit more about yourself and what it is you do.
Absolutely. So I'm a radiation oncologist, and I specialize in the treatment of gastrointestinal malignancies. I think the first question often is, well, what is radiation therapy and what is a radiation oncologist? So I'll address that first. So radiation therapy is the use of ionizing radiations to kill cancer cells, one of our main modalities for the treatment of cancer, along with surgery and, of course, chemotherapy. We deliver our radiation from a linear accelerator, a machine that basically, I would say, precisely targets high energy X-rays towards tumors, leading to DNA damage in the cancer cells and cell death. And so I found myself in radiation oncology because I really liked the multidisciplinary aspect of care, both within our department. We work with physicists who help us devise the plans, along with medical dosimetrists, and also a great team of radiation therapists who deliver the daily treatments for our patients. And found myself specializing in GI cancers, mostly because the opportunity arose when I was early in my career.
And so can you tell us a little bit more about, what kinds of GI cancers you target in particular and you work most commonly with? And how does radiation therapy really play into those patients' treatment algorithm?
Absolutely. So in the GI tract, the main cancers that we employ radiation therapy for would be esophageal cancers, pancreatic cancers, colorectal cancers, some liver tumors, and anal cancers. And so for some of these cancers, the radiation therapy actually is critical to cure the cancer. We can use radiation therapy in conjunction with chemotherapy to cure anal cancers as well as esophageal cancers. Sometimes surgery is also employed for patients with esophageal cancers. For the other cancers I mentioned, we use radiation therapy as what we would call part of a combined modality treatment program. So along with chemotherapy and surgery to give patients the best outcomes. So for example, in pancreatic cancer, radiation therapy is often employed prior to surgery to help improve the likelihood of achieving a complete resection of a pancreatic tumor. And then we also use radiation therapy for those patients who may not be candidates for surgery. And we are trying in that instance to provide local control of the tumor and often to control the onset of local symptoms that may be a result of a cancer growing in a particular location.
Terrific. So it sounds like radiation therapy has all kinds of utilities for many different cancers in the GI tract. Now, at the top of the show, you had mentioned this new technology, RefleXion. Can you tell us a little bit more about what exactly that is and how it plays into the workings of radiation therapy for these patients?
Absolutely. So the RefleXion is a linear accelerator, which I mentioned is the machine that directs focused radiation beams towards tumors. And what's unique about the RefleXion is that it combines PET imaging technology with radiation therapy. So I think to better understand how the RefleXion is novel and what the benefits are, it's best to probably first talk about what is a PET scan and how is that used in combination with radiation therapy on the RefleXion. So a PET scan is a common imaging technique, as you know, used in cancer care. These are scans that are a standard way to image tumors, I would say screen for sites of metastases and also monitor response to treatment. The way a PET scan works is that we first inject a radioactive tracer into the patient. The radio tracer can be used for cancer detection because it's a glucose or a sugar analog that is attached to a radioactive marker. So that means that active cancer cells will consume more of the radiotracer. We call it FDG for the most common type of PET scan. And it consumes that FDG at a greater rate than normal healthy tissues. So the radioactive signal can be detected and then reconstructed with a CAT scan. So you basically get a three-dimensional image where the amount of tracer uptake would correlate with the metabolic activity, or I would say the tumor activity in that area of the body. Basically, a PET scan is a whole body scan, and it shows us where tumors are located in the body, and how much the areas light up on the PET scan would correlate with how active cancer cells are in those areas. So on the RefleXion, the SCINTIX technology, which is the technology, basically the program that has been incorporated into this LINAC, tracks the PET tracer emissions from cancer cells. And that is used to determine where to direct the radiation, even if a tumor is moving during treatment. So the novel technology is combining the PET imaging as a means to guide where and when to deliver the radiation therapy.
Well, so that sounds really exciting, but also it seems to kind of make sense that you would have some sort of an imaging modality to direct the radiation therapy to what you wanted to treat. Prior to this RefleXion technology, how was that being done?
So what we do for radiation therapy is we start with a planning CAT scan. This is a three-dimensional image of a patient in the position for radiation treatment. And we use those images to define the target volumes, being the tumor and any at-risk areas, as well as the normal tissues that we want to try to minimize radiation dose delivery to. With those CAT scans, we generate a plan to direct the radiation at the sites of interest. And we deliver that plan on the LINAC with very focused beams that are shaped across the face of the beam to match the shape of the tumor from the angle that the beam is being delivered. We combine that with imaging on the machine on a daily basis. So we can obtain a CAT scan or X-ray imaging to look at the patient anatomy on the day that they come in for treatment and move the patient on the treatment table in order to get the patient in position for treatment. What this does not help us see is motion that occurs during treatment. And that's where the RefleXion technology really is novel in providing added benefits.
And so, it sounds like this technology is certainly exciting in the sense that it can see tumors moving, but it also sounds like it might be really expensive. So I have just a couple of questions. One, how expensive is this, and is it covered by insurance? And two, how often do tumors really move during treatment? In other words, is this really something that's necessary for the vast majority of patients, or could this simply be added expense?
So this is currently approved by insurance companies, and the cost to the patient would be no different than the cost of a program of radiation therapy that is approved by your insurance company, with the added cost to the insurance company, of course, of the PET scan that would be delivered for treatment planning and during treatment, but that it has been approved by insurance companies, and we would, of course, make sure that's authorized prior to proceeding with any treatment. In regards to the tumor motion and how this is beneficial, I think, it would be interesting to talk about treatment of a lung cancer to try to envision how the RefleXion technology really provides benefits. So how often patients' tumors move would be very common when we're considering a lung cancer, for example. So this means that when you're targeting a lung cancer, you're basically trying to target a moving target with radiation, precisely, right? So typically how we would take this into account with radiation therapy is that the radiation field would have to be expanded to encompass the path a lung tumor takes while the patient breathes in order to fully dose the radiation to the tumor. And we also have to take into account not only motion of tumors, but also motion of the patient. So a patient may move, and even a small amount of motion say millimeters during treatment, could move the tumor outside of the high dose radiation region. So we would further expand the radiation field to take into account that potential motion. So with the RefleXion, they're calling it biologically guided radiation therapy. So rather than taking into account the natural motion of the tumor or the motion of a patient with larger treatment fields, the field can be smaller because the PET signal from the tumor is tracked by the RefleXion to guide where and when to deliver the radiation. So you can imagine it is as if the radiation treatment plan is moving with the tumor if the tumor naturally moves, such as a lung cancer, or with the patient if the patient may wiggle a little bit on the treatment table during treatment.
And so if you can narrow the radiation field to just target the tumor and not have to expand the field to account for all of this motion, you might have fewer side effects too, right?
That's exactly what I was going to say, Dr. Chagpar. So the main benefit really is that we can reduce the volume of normal healthy tissue surrounding the tumor and the exposure of those tissues to high doses of radiation, and that in turn can significantly reduce side effects.
And so, it sounds like this is novel technology. Has that actually been looked at in terms of studies where you can actually say that there is a X% difference in terms of the side effects that patients may have to face? So, for example, in the case of lung cancer, that there might be less radiation-induced pneumonitis or less cardiac toxicity with the use of this new technology versus what we have historically always used?
That's a great question. So what has been studied so far, since this is such a novel technology, is that with the PET tracking, you are in fact delivering adequate dose to the tumor, and if anything, able to better deliver an ablative dose and full coverage of the tumor while it moves during treatment. What we have open right now at the Smilow Cancer Center is a registry trial. So this is a trial that for patients who are being treated on the RefleXion machine, we are collecting data prospectively in terms of their tumor type, outcomes in terms of response to treatment, and using that data in order to understand their response to therapy, how to predict response, but also being able to quantify how the delivery of treatment on the RefleXion might reduce the risk of side effects.
Fantastic. Well, we are going to talk more about these interesting breakthroughs in terms of radiation therapy. But first, we need to take a short break for a medical minute. Please stay tuned to learn more about this breakthrough radiation therapy with my guest, Dr. Kimberly Johung.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program is comprised of a team dedicated to managing the diagnosis, evaluation, and treatment of urologic cancers, including testicular cancer. SmilowCancerHospital.org. Genetic testing can be useful for people with certain types of cancer that seem to run in their families. Genetic counseling is a process that includes collecting a detailed personal and family history, a risk assessment, and a discussion of genetic testing options. Only about 5 to 10% of all cancers are inherited, and genetic testing is not recommended for everyone. Individuals who have a personal and/or family history that includes cancer at unusually early ages, multiple relatives on the same side of the family with the same cancer, more than one diagnosis of cancer in the same individual, rare cancers, or family history of a known altered cancer predisposing gene could be candidates for genetic testing. Resources for genetic counseling and testing are available at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Kimberly Johung. We're talking about a new breakthrough radiotherapy. It's actually a technique called RefleXion, which kind of pairs radiation therapy delivery with what sounds like real-time PET scan techniques, essentially allowing radiation therapists like Dr. Johung to kind of track that tumor as it moves and as patient moves during therapy with the PET imaging and deliver the radiation therapy more precisely. So, Kim, you were talking earlier on about this technology, and you were saying that you actually specialize in GI cancers. So I know we kind of took a little bit of a detour to kind of get a sense of how this technology might work in terms of lung cancers, where you can imagine that as people breathe, their tumors might move. Can you talk a little bit more about its particular utility in GI cancers?
Absolutely. So we did talk a lot about how the RefleXion can optimize the treatment of cancers that move during treatment, and where this comes into play for GI cancers would be in the delivery of what we call stereotactic body radiation therapy. So stereotactic body radiation therapy, that's a mouthful, so I'll call it SBRT, is a specialized type of radiation therapy in which very precise high doses or ablative doses of radiation can be delivered to small tumors. So typically between 1 to 5 treatments for tumors that are very localized. And in this situation, it becomes very important to precisely be able to track tumors. So we know that stereotactic radiation can be an effective non-invasive way to treat not only early stage lung cancers, but also liver tumors that may not be able to be resected, pancreatic tumors that also cannot be resected, or metastatic sites with these ablative doses that can be effective without concurrent chemotherapy. So I did mention the liver tumors and the pancreatic tumors. Those would be primary tumors that develop in those organs. But for metastatic sites, one area where SBRT has very promising data is in the treatment of oligometastatic disease.
So tell us more about that. What exactly is oligometastatic disease, and how does this work in those patients?
Absolutely. So oligometastatic disease would be primary tumors that arise if we're talking about the GI tract, we'll use, for example, the colon or the rectum, and then have spread to a limited number of sites, typically under 5 sites. And what we've seen is that this is a subtype of metastatic disease where patients actually can have very good outcomes, that we can see long-term survival. And this is achieved with definitive treatment of the primary tumor. So that would typically involve chemotherapy, surgery, often radiation therapy to address the primary tumor. And then if a good response is achieved, you can provide local therapy to those 1 to 5 limited sites of metastatic disease. So local therapy can be surgical resection, but when surgery for these metastatic sites is not feasible, particularly if we're talking about multiple sites of oligometastatic disease, then SBRT, or the stereotactic radiation, can provide high rates of local control with minimal toxicity in a way that's non-invasive. And there are other local treatments that can be provided for oligometastatic disease, such as ablation techniques like microwave ablation or radiofrequency ablation.
So in terms of using this technique of RefleXion, it sounds like that is really specific to ablating these tumors with SBRT as opposed to microwave or other techniques that you mentioned. Is that right?
Yes. So the RefleXion technology with the PET tracking, or biologically guided radiation therapy, as we're calling it, really is to be used in conjunction with radiation therapy for the delivery of stereotactic body radiation therapy. And that right now, the BGRT is approved for the treatment of lung tumor sites and bone tumors. though we expect those disease sites to expand. So when we're talking about GI cancers and the use of the RefleXion technology, where it really would come into play right now is for the treatment of oligometastatic disease in the lung or the bone from a primary GI cancer.
One would think that if it was good to treat lung cancers where they move, and perhaps bone oligometastatic disease, just because of the intensity. It sounds like when we're doing these ablative therapies, it's really a more intense form of radiation therapy than standard radiation. And so when you're targeting these metastatic sites, you want to be more precise about it. Is that right?
That's correct. So when we're delivering the stereotactic body radiation therapy, each dose of radiation on a particular day can be up to upwards of 10 times the amount that we would give on a standard radiation therapy program. And so there it becomes extremely important to be very precise with where that delivery of radiation is, and to protect the surrounding normal tissues. And when we discuss the ability to reduce the treatment field with the use of RefleXion technology, that benefit in terms of decreasing the risk of normal tissue exposure really is increased when you're delivering the higher doses of radiation for SBRT.
Yeah. When we think about colorectal cancer, for example, it seems that, we would think that the most common place for colorectal cancer to metastasize would be to the liver. And so is there a reason why RefleXion currently isn't used for these oligometastatic sites in the liver? Or did I misunderstand and it really is being used in the liver?
We expect that the RefleXion technology will be used for oligometastatic in the liver because, as you mentioned, especially for colorectal cancer, this is often where we see sites of oligometastatic disease and where we've seen excellent long-term outcomes. So what is in development right now is being able to detect the PET tracer activity from the metastatic site or the tumor site in the liver and be able to differentiate that from the background uptake because there is a certain degree of background PET uptake in the liver. So to be able to precisely track a liver tumor, one must be able to have a ability to differentiate some slight differences in PET avidity or PET uptake between the tumor and the normal tissue.
You really can use this technology when the PET scan is able to show you a spot that lights up that's very different from normal tissue. And if that degree of separation isn't always present in the liver, then there might be more work to be done in that area. I can imagine that another metastatic site where it would be really helpful to be very precise about targeting radiation therapy would be the brain. And so is it the same kind of consideration for using this technology in the brain, the idea that there might not be that difference in terms of resolution between background and signal?
Exactly. So we often don't use PET scans in order to detect brain metastases for that very reason that you mentioned, Dr. Chagpar. And thankfully, brain metastases or primary brain tumors typically don't move as much during treatment. So we have other ways when we're delivering high doses of radiation or stereotactic radiation to make sure that the patient doesn't move during treatment, such as immobilizing the patient very precisely on a different platform for stereotactic radiation delivery, which is called the Gamma Knife that we do have at our cancer center.
And so we've talked a little bit about using this technology for targeting these oligometastatic sites for ablation, particularly in the lung and in bone. Does it have any utility in the GI tract for treating primary cancers, for example?
So currently, I think that there are benefits that will be coming into development because GI cancers by nature will move with respiration or with normal movement of the gut or the organs within a patient. And so I think that being able to more precisely differentiate, as you mentioned, the PET uptake or activity from a tumor to those background organs will be critical to moving forward with using this technology to treat primary GI cancers.
Yeah. What about for other tumors? I mean, you mentioned that for lung cancer, it seems to make sense to use this. I would imagine that this is now being used for primary lung cancers. Is that right? And is it being used for any other cancers?
So currently we're focusing on early stage lung cancers for patients who are not surgical candidates, where we do see excellent outcomes with stereotactic body radiation therapy. And so that would typically be 3 to 5 treatments to the lung. Outside of that, the focus is on oligometastatic disease. And right now we are limited to treatment of metastatic sites in the lung and the bone. We can use the RefleXion technology to deliver treatment without the PET guidance as well. And there are benefits to treatment on the RefleXion outside of the biologically guided radiation therapy. So this would include basically any tumor site. And we can deliver intensity modulated radiation therapy using the RefleXion machine. So intensity modulated radiation therapy is different from stereotactic radiation in that we are now delivering small doses of radiation on a daily basis, typically over the course of weeks. And the reason for the small doses over days, every day over weeks rather, is that allows the normal tissues to heal in between each treatment. So while we are taking into account tumor motion, it is less critical because we do have the time in between each treatment for normal tissues to heal. The benefit of the RefleXion technology is that we do have high quality imaging on the RefleXion machine such that we can use a CAT scan or a high quality CAT scan or a pair of x-rays in order to align the patient for those daily treatments on the RefleXion. So not only can the RefleXion deliver the biologically guided radiation therapy with PET guidance, but also can be used to deliver more standard radiation therapy such as IMRT.
And so in terms of using the RefleXion without the PET, I mean, is that with like continuous imaging? How is the RefleXion without PET any different than a standard linear accelerator?
Well, one of the benefits of the RefleXion actually is the ability to treat multiple tumor sites at the same time. So typically, we'll go back to the example of the oligometastatic sites, right? So if you were not to use biologically guided radiation and you are treating multiple tumor sites at the same time, this would typically require one treatment plan for the first site and then realigning the patient and treating the second site. But the RefleXion is able to simultaneously deliver treatment to those two sites at the same time. And if you were to be treating a tumor in the lung that's moving, it would be able to track and treat those two tumors at the same time. So the benefits would be the ability to treat multiple sites simultaneously, and also that while the RefleXion does provide the typical radiation treatments that other LINACs provide, we have found that the quality of the imaging that we take before each treatment is delivered is of a higher quality, such that we are better able to discern borders between normal tissue structures and the tumor and make sure that the patient is aligned with millimeter precision for treatment.
Dr. Kimberly Johung is an associate professor of therapeutic radiology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.